A very good afternoon to everyone. It's always a tough thing coming after Pete, after his really awesome talk, but I shall try and keep you guys entertained. So, good afternoon. My name is Tim, and my topic today is on meniscus preservation. How far should we go? Before I start, I just want to thank you to our host, TOSSM, and Professor Bancha for the opportunity to come and share at this exceptional conference. Thank you for your very, very kind hospitality. So we all know from our knowledge of basic science that the meniscus is extremely crucial to having a healthy knee. The meniscus helps to increase contact surface area and prevent excessive loading in the knee. This in turn helps to protect the cartilage and subchondral bone in the knee from damage and wear. Both the medial and the lateral meniscus are important secondary restraints in the knee. They play a role in load sharing with the ACL to provide translational and rotational stability, and even more so in a cruciate deficient knee. So the loss of a meniscus can lead to disastrous effects on the knee. We know from Dr. Fairbank's research in 1948 that meniscectomy will lead to arthritis, happening much sooner than we expect, sometimes as early as 5 months. Doctors Pernin and Verdonk have also shown more recently in this multi-center study with long-term follow-up in patients undergoing ACL reconstruction that the lack of meniscus almost doubles your chance of getting osteoarthritis in the long run. This further highlights the link of the meniscus or the lack of it to arthritis. So most of the time, the decision to repair the meniscus is pretty clear-cut. The meniscus repair of a simple vertical tear often gives us very predictable results with up to 95% chance of it healing. However, meniscus tears come in all shapes, types, patterns, sizes, and chronicity. It's a bit like Forrest Gump's quote, right? Life is like a box of chocolates. You never know what you're going to get. So meniscus tears with a more complex tear pattern always leaves us with a dilemma whether to resect or repair. So this is a patient of mine. It's a 24-year-old gentleman who had a valgus and rotational injury to his knee. The clinical findings suggest the presence of an ACL and low-grade MCL injury. The MRI confirms this and also shows a posterior horn body junction radial tear. So I remember coming in for Adam's talk just now, and he was talking about the radial oblique tears. This was one of them. So repairing a radial tear is always tricky. The repair sutures are along the longitudinal fibers of the meniscus, making it difficult, making it much easier for it to tear through. In the lateral meniscus especially, there's also a lack of capsular attachments to allow for its mobility. Using traditional suture anchor devices, there's a tendency to overtension and pull the meniscus onto the capsule and off the articular surface, resulting in a non-anatomical repair. So in this particular case, we proceed to do a 6-strand ACL reconstruction and a lateral meniscus radial repair. So this is that meniscus tear from that patient, and after rasping and debridement, we can see a large radial oblique tear, and the first step is to do a locking cinch stitch across the tear site. So this acts as a rip stop to prevent cheese wiring and tear out and tear of the sutures, and helps us to get the right tension. Then we pass the sutures multiple times across the tear site so that it can help to share the tension across the repair. And after which, we try and tie this on the undersurface using half hitches to minimize impingement. So experience so far with about 27 patients with short-term follow-up, the results look promising. We'll be looking to publish this data with longer follow-up. So should we repair radial tears? I think the short answer is yes. This is a study from the Mayo Clinic looking at bucket handle meniscus repairs and radial meniscus repairs. And radial repairs have about 10% failure rate at 2 years, 20% failure rate at 5 years. And that seems pretty reasonable for us to want to attempt a repair. A more recent systematic review by Dave Flanagan's group in Ohio also echoed the same views. There was significant improvement in both the post-operative scores and healing rates. And healing rates were as high as 90% on second look arthroscopy and MRI scans. Okay, so this is another patient of mine with an old knee injury. He now presents with increased pain and locking. The MRI confirms the ACL tear, a bucket handle medial meniscus tear, and a lateral meniscus root tear. So we go ahead with the surgery, ACL reconstruction, and attempt to repair both menisci. And if you look at his surgical video, right, he has a bucket handle medial meniscus tear, which is displaced into the notch. And the first step, as always, is to actually get a good exposure with a medial pie crust. This is a technique described by Professor Bancha and his team at Thammasat University, and it's extremely effective in getting good exposure without much risk and damage to the saphenous nerve and the MCL. So as you can see, when we look at the video, the medial meniscus is extremely scarred down, deformed and contracted. Here we are trying to use a reduction stitch to gain some control over that meniscus. And so, we pull on it, and we just try and reduce it, but it just won't go. So we just slowly try and, debride the front to release some of that scar tissue to reduce that meniscus. No, but it just wouldn't go back. So at the end, of the day, we compromise. We take down the anterior horn, reduce the posterior horn, and do a selective repair of the posterior horn. So the rationale for doing that is that the posterior horn will at least help to contribute to the anterior posterior stability of the knee, so that it's able to help to share some of the load with the ACL when we do the ACL reconstruction. And there's also some evidence that the more meniscus that you take out, the earlier, the onset of the arthritis. Okay. So we've secured the repair, and then we go ahead and proceed with our lateral meniscus root repair and our ACL reconstruction. Okay, this is Professor An's paper in AJSM. It's a biomechanics study which highlights the importance of the posterior horn of the medial meniscus and anterior posterior stability in the knee. So repairing the posterior horn will decrease anterior translation of the tibia and help to load share and protect the ACL. And meniscus salvage is not a new idea. These are two high-powered studies with large numbers and medium-term follow-up, looking at partial meniscectomies and total meniscectomies. And the patients with more meniscus preserved, they do better in terms of function and stability with better clinical outcomes. So it's important to try and preserve as much meniscus as possible. Okay. The final patient is a 35-year-old gentleman. He had a bone patellar tendon bone ACL reconstruction and medial meniscus repair done 6 years ago to his right knee. And he had another ACL reconstruction done on his left knee 11 years ago. So he was able to return to basketball after both his surgeries, but he has this recent new injury to his right knee. So he complains of now mechanical pain after a twisting injury. Clinically and radiologically, his graph is stable. And as what Pete says, look for the alignment, the alignment of the right knee looks good as well. And as you can see, when you scope the knee, the ACL graph is intact. Looking at the medial compartment, you can see grade 2 to 3 wear over the medial femoral condyle, but it isn't too bad. But what really sticks out is a loss of meniscus tissue from the previous failed repair. So after debriding the bit, you notice that there's an intact rim and root. And one option is to do a partial meniscectomy, and just go out, and leave the patient with partial meniscectomy. But in this particular case, we put in a meniscus scaffold. So the first step, of course, is to secure the posterior edges of the implant. And then, we don't over tension, and we go on and secure the anterior part of the implant. So there are two types of scaffolds generally. One is a collagen-based implant, but this is a polyurethane meniscal scaffold. And what it does have is it's shaped like a sponge, so to allow for ingrowth of like host tissue. So after we secure the front and back, we do sequential tensioning before completing the fixation, with like a couple of over surface and under surface suture anchors. Okay, so this is a recent multi-center trial involving some of the big names in knee preservation in Europe, and results of these meniscus implants look pretty reasonable. We're looking at about 15% failure rate at 5 years, with good improvement in the clinical scores. We do note that the results of this study are significantly better than some of its earlier studies on this procedure, and I believe this is due to the stricter inclusion criteria. This criteria is pretty similar to that of a meniscus transplant. Any instability, malalignment needs to be corrected. The cartilage cannot be too far gone. But the main difference for a meniscus implant to work is that the meniscus root and the meniscus rim needs to be intact. Yeah. So, meniscus implants are not a perfect solution, but I believe this provides an option, for patients with significant meniscus tissue loss and as a bridge before the meniscus transplant. So, in summary, the meniscus is very crucial to prevent excessive loading and to provide stability in the knee. And as we all know, meniscus preservation is important. This is an evolving field where improving implants and techniques and better understanding of biology will help us achieve better results. Thank you for your time. Appreciate it.
Thank you, Tim, for the presentation about the importance of the meniscus, the role and the functions of the meniscus, as well as the consequences of the wrong treatment and the loss of the meniscus. May I welcome any questions from the floor? Because Tim has to take the flight back to Singapore as well, right?
Yeah.
Or you take the boat?
Maybe a boat.
Okay, maybe Bancha can arrange the boat from the beach of Pattaya directly down south to Singapore. Any question?
Good afternoon. Myself, Dr. Sharat from India. Hi. This meniscus scaffold I have not seen in India. Where is it availability and how did you procure it?
And how do I what? Sorry.
Yeah, it is available from the like a company, or we have to.
Yeah. So it's sold as an implant, you know, and you know you can. You can. Basically, it's sold as an implant, and basically, you order it.
It has a shelf life, and it's sold in the pre-sterile packs.
Oh no, it's synthetic. So the one that I'm using, the one that's available in Singapore, it's a polyurethane-based implant. So it's totally synthetic. Okay. So you don't have that issues, with like preservation. Okay. So just like a standard implant, the shelf life is dependent on the packaging and all that. So
it comes as medial and lateral separate?
So you've got medial and lateral. And
separate.
Yes.
Okay. And the curvature is same or small, medium, large or something like that?
No, it's a standard size. It's a standard size. And basically what you do, if you've seen the video, at the start of before you actually insert it, you use a ruler to measure it. Yes.
Okay.
So you measure it, you cut it, and you insert it, and then you just stabilize it. So then you just treat it like a meniscus repair.
Okay. Thank you.
Any more question? Can I ask you about the price of the meniscus scaffold?
Yeah, so it's not cheap. It's not
cheap.
I
know it's not cheap.
In Singapore, I think the last I heard it was being sold for about, the last ones that we put in were about $2,000. Yeah. Just 2,000 Singaporean dollars, which is about maybe 1,200 or 1,300 US dollars. The problem now is that there seems to be a shortage of this implant because they're not making enough to meet up the demand. So it's been out of stock in Singapore for the last, I think, 6 to 7 months. Yeah. Do you have something similar in Thailand, or?
Any more question?
You mean the CMI, right?
Yeah, so there are two types, right? One is the CMI, and this is the totally synthetic one.
Okay. Yeah. So previously there's like segmental loss, you can put the CMI.
Yeah.
But totally, they prefer to use meniscal allograft, right?
That's right. So I think you need an intact meniscus root, and you need an intact meniscus rim. Yeah. So this works totally the same as like a CMI. It's just that this is purely synthetic and the CMI is collagen based. Yeah.
Thank you.
You have any comparison study between the allograft of the meniscus and the scaffold, which is the artificial one?
I think it's a different group of patients,
Right.
you know, and
So
I think the
it's a partial
indications are a bit
defect or
different.
total defect,
Yes,
right?
that's right.
Okay.
Yeah.
Okay, I think